So a few things to remember, for EUS, there's going to be a lot of repetition. So every case, pretty much the same case. Unfortunately, human haven't changed since Allah created them. So it's the same anatomy most of the time. And in last probably 8-10 years, nothing much changed major. Some interventions came, but it's the same procedure, same scope pretty much, some advancement in the scope, some advancement in the equipment, but overall is same. So it's going to be a repetition, repetition, repetition. And some of you probably have seen this talk, heard this before. So again, it's same thing is you have to go through over and over and over. And we're going to be talking about the same thing during all those cases. Other thing, even though I was talking not bad about elastography, so everybody has all these elastography, contrast, everything has their role in their domain. So some people like me, we don't use it much, but that doesn't mean really like it does not have a functional role. So jokes aside, but obviously. Okay. No, just wanted to make it clear. Yes, specify. So EUS, I think Mustafa has gone over a lot of stuff. There's going to be, again, some of those are common and repetition. So it has a really, really good accuracy and really, really good resolution. You can see such a small lesions with that, 5 millimeter lesion, 3 millimeter lesions, and you can even guide your needle into those as needed. Not that we have to do that all the time, but it has such an accuracy. You can see structures really. It's a safe procedure, so we don't need to make it unsafe. And so go slow in the beginning, especially. And you're going to have a trouble intubating. You're going to have a trouble interpreting images. Not be discouraged with that. It just takes time. It's a really, really steep learning curve. As endoscopists, we really don't like black and white. We like red blood and white. So this is, it takes time. You have to switch a button in your brain, like constantly you are switching from endoscopy to radiology. So you have to train your mind with that. So it takes time. One quick thing Mustafa already mentioned about that, radial, probably you are not going to use much of that scope because you can do pretty much everything with the linear scope. And the fellows coming out nowadays, even in our institutions in United States, many of those, they have really I shouldn't say no experience, very minimal experience with the radial, and they're not comfortable at all with the radial examination. When I trained, it was transitioning from radial to linear mostly, the older generation. The way they used to do it, they would do a radial first, do the exam, and then use linear just for biopsy or intervention. So that was the initial linear role. Now it has completely switched, and radial is not much used, but radial is, it's a 360 image. It's like a CT scan, that's it. And you're doing a CT scan, but it's a limited CT scan, okay? It's not like a full like body exam or a full abdominal exam. So some of patients, really, they come and they're like, oh, can you look around and see, make sure other things, other organs are okay? And my answer is usually to them is, it's not a car mechanic shop that you can look at the car and figure it out. So we're going to do one thing at a time, really. So here with regard to the linear, we use linear. It has a transducer which is parallel to the shaft of the endoscope. That's another reason. If you look at here, that's the one reason we use this scope for any therapy, any FNA. You see this needle, this is coming right in front of the transducer. That's why you are able to see that. If I go back on the radio, you see where the transducer is. Working channel is going to be right here, right? So that's why you're not able to see needle, so you can't use that scope for any therapy. Here, the needle comes out of the working channel here, and that goes right in front of the transducer. So the whole time, you have the view of the needle. And so use this for any intervention. Also, there's a Doppler, so you can take a look at the vessels. Just make sure to avoid those. If you use a smaller needle, sometimes it's okay to go through the vessels. Not a big problem, but don't keep puncturing the same vessel over and over again. Mustafa already showed those scopes. This is a radial scope, this is a linear scope, and this is an endobronchial ultrasound. So that scope is really a small scope and used by the pulmonologist. Okay, so principles of imaging, again, it's going to be repetition because Mustafa has gone over some of those, but it's a station-based approach. You can develop your approach really. For me, when I started doing the EUS, what my mentor told me, do a complete exam every EUS you are doing. Even if it's for submucosal lesion, he would make me do the complete exam. So it has come to the point that every station is registered in my mind. Sometimes nowadays, I may go to a focused exam first, like I gotta go take a look at the submucosal mass. But for all those reasons, repetition and repetition, I end up doing a complete exam, but it takes me less than 5 minutes to do that. So when you get train your brain, train your hands, there's a good coordination. It really does not take much time when you become an expert. But make a habit of doing your own station-based approach. I think the stations they made, they are wrong. They don't apply really. Because the station don't start, the stations what they have told, which are in the books, they start from D2. But we start from GE junction usually. So I don't think those stations, I'm going to go through those stations the way they are described in the book. For me, first station is GE junction, and that's how I'm going to explain it to you, because I'm going from top to bottom and then coming back all the way. Okay, 5 and 6 still apply to me because that's a mediastinum. So I will do that at the end, but first station for me is GE junction, and that's where I start. We have this concept in our mind that that's how the anatomy should look like, but that's not usually it is. So you have to do really a lot of teaching, watch a lot of videos, whatever is available, look at the anatomy atlas, make up this image, sketch in your brain that if you are at this station, what you should be looking. I literally, personally, myself, I have done all that. I have looked at different atlases. I have sat down, imagined like what if my scope is in this position, what I should be looking at. So it really takes time. It takes an effort. You really have to just spend your time. Nothing comes for easy. All of us want to become expert the first day we touch the scope, but it really takes time. It takes a lot of hard work, takes a lot of effort. So, and make the anatomy fit the station and just don't guess based on what you think the anatomy should look like. Many times you're going to get lost, especially in the beginning. The easiest and the best way is to go to your familiar station or the bigger vessel, whatever you know. And that's usually is going to be aorta at the GE junction if you're looking at that. So go back there, spend a little bit time. Even though here I said if you're lost, spend 1 minute to find your way, you may have to spend a little bit more time in the beginning. You may have to spend a couple of minutes, 2 minutes, 3 minutes. If you don't find it, just come back. There's no harm. You're not going to hurt anything. Just come back and start over from the familiar station. And we talked about the pulse Doppler. We talked about the color Doppler. So I think they have a camera. I'm going to do one case after this, which is going to be just a demonstration. I'll show the hand movements, show the shoulder movements, show the wrist movements. So it's a very like coordinated, slow movements in EUS. That's what you have to do because you move a little bit, a lot of portion changes. So you have to do very coordinated, slow movements. We talked about these scopes already. So this is a cartoon. These are the cartoons which I got first as soon as I started fellowship. That was in 2008. So this is just shows you all the organs, and when you move your scope, from GE junction downwards, look at where the those ultrasonic waves are, and when you are moving down, what you are looking at. Okay, and I'm happy to share these two with whoever needs it. These ones I looked over and over and over and over, and just to get some idea what I'm looking at. Okay. So you can see that this is moving toward the duodenal bulb, and that's where you look at the head of the pancreas, you're looking at the bile duct, you're looking at the portal vein, and see how you are doing the rotation of that scope and what structures you are looking at. So that's from the duodenal bulb. This is going to be from the second part of the duodenum, which you are mainly looking at the uncinate process, and also you look at the mesenteric vessels from there, especially SMA and SMV. Also, you can see the ampulla. That's obviously the station for ampullary exam, this one and D1. You can take a look at the bile duct. You can take a look at the pancreas. Hopefully, I can demonstrate that, but 80 to 85% of the time, when you are in D2 at the ampulla, from that station, you can take a look at the whole pancreas with one movement, starting from there all the way to the tail by the right movement of the scope within 30 seconds. Like it just moves from ampulla, uncinate process, the way you move the scope and pull it back into the stomach, you can see the whole pancreas really in a very short duration of time. Again, it will be repeated during the live case, but neck of the pancreas, I just want to stress that. That's the area which I tell my fellows you should, my trainees, you should take a look at that from 3 different stations. One is from the stomach, one is from the duodenal bulb, one is from the D2, and I'll show that. Okay. So the radial, just to quickly go through that too, same concept. You see how it's looking. The movements of the radial scope really are not much different than the linear. Okay, it's pretty much same movements what you are gonna do, but this is you can see that how you're looking at the pancreas. Some difference with this is when it's like a CT scan image. So when you're looking at the pancreas with the linear, you're going from right to left. Okay, so the section of the pancreas are like straight through the body like this with the linear. With the radial, it's like a CT scan. So you have, with the linear, you go right to left. With the radial, you have to go in and out to take a look at the whole pancreas, because that's like a CT image, like this. So that's the major difference between the radial and linear. But overall, really, there's not much difference between the movements of the radial and linear. So this is when you go into the D2, D1 and D2, really not much difference between the radial and linear movement. And when you are in D1, usually you are in a long position of the scope. What that means is the scope is really resting on the greater of the greater curvature of the stomach. And that gives you a little more stability of the scope, because you shouldn't be falling back with that scope, and it's in a stable position. And the same thing is same position when you are in ERCP. If you keep falling back, sometimes it's better to go into the long position, what we call. What that does is that you rest on the greater curvature of the stomach, and that stabilizes your scope. So the station 1, 2, 3, I already mentioned about that. That's not my stations. That's not how I do it. My station, which is station number 4, is number 1. And then then I go with the station 2 for me is really, which is 3 here, 1 and 2. They are 3 and 4 and 5 and 6. That's how I do. So GE junction and stomach, station 1, duodenal bulb, station 2, and second part of the duodenum, station 3 and 4, and then mediastinum, station 5 and 6. But this is how it's been described in books by my mentor, Dr. Haas. He's one of the first one who wrote a EUS book. So that's how they describe it. So I really don't argue with him that he's wrong. And but whatever, that's okay. So these are the stations again, and this is what you're going to look at the anatomy there. Mustafa have gone through that, so I would not go through that anymore. These are the really old videos, and these are from Dr. Ha's book. And when he was at MUSC, when he wrote the first EUS book. So I think hopefully there is a volume on that. I can turn that on. This one of the his fellows who made an audio on that. I don't know if it's going to work or not. And is Shariar here? ये इसका ना इसमें से वॉल्यूम आना चाहिए लैपटॉप में से. So that gives me a little rest because somebody else is talking and you can listen and I can take a little bit rest. आएगा ये नहीं? अच्छा. वो कर रहे हैं. इसमें खुद वॉल्यूम चला जाएगा ना. अच्छा. मैं गिरा दूं. जी. किसको डिसेबल करना पड़ेगा? HDMI का आउटपुट. ओके. हाँ जी.
In this video sequence, you can see the advancement of the scope into the duodenum. With initial imaging, one can see the aorta clearly across the imaging field. Now, one needs to slowly withdraw the echo endoscope. And with withdrawal, one needs to apply clockwise and counterclockwise torquing in order to image the pancreatic uncinate. As one withdraws, the aorta is typically out of the visual field. It may dive deep into the pancreatic head. On this video, one can see that as we have withdrawn, we have come up squarely on the pancreatic uncinate, and we can now visualize the pancreatic duct. Torquing left and right brings the aorta back into view, and at the same time, we can see the pancreatic duct and the uncinate of the pancreas.
So I think there are better images on that.
Again, we cannot overemphasize the clockwise and counterclockwise torquing that is necessary to fully interrogate the pancreatic uncinate.
G2. So it's they started it according to their station.
One can clearly see the pancreatic duct, which typically comes from deep within the pancreas, whereas the bile duct is seen closer to the duodenum. Color Doppler can be applied to differentiate vascular from non-vascular structures. With further torquing, one can see the bile duct as well.
So here I again I'll explain during the live case as well. What I usually say is when you are in D2, there are 5 structures you're gonna look for, okay? And those 5 structures have aorta. Aorta being a dominant organ, it's right in the middle of those 5 structures, okay? From aorta, if you go to the right, the first thing you're gonna find is the bile duct. Obviously, you will be looking at the pancreas. Second thing is gonna be the pancreatic duct. It's almost always the same sequence, okay? So aorta, rotate to the right, first thing bile duct, then pancreatic duct, and you're looking at the pancreatic head and uncinate process too. From there, if you torque left, you look you see IVC, inferior vena cava, and the right kidney. So this sequence is almost always the same from D2 when you are doing these movements. So hopefully I will demonstrate that in the live case. So this is a station 2, which is really a ampullary area, and there are two ways to really take a look at it, but I'll let you go through this, and then what happened to the D2? Yeah, so they call a station 1 really for the uncinate process. Station 2 is really an ampullary area. It's a pretty much same though, both of those areas. What happened to the volume again?
Slightly deeper to station 1, right?
Yeah, it's a slightly a deeper in a sense. I think I don't know why the volume is not coming. ये volume को क्या हुआ मेरे भाई? Volume on है? पक्की बात है? नहीं, आपने ये कर दिया ना वॉल्यूम, इसको ऑफ करना पड़ेगा, स्विच करना पड़ेगा. अब anyway, so I will go ahead and explain that. When you are looking at the ampulla, there are really two ways to take a look at that. So one thing is you take a look at endoscopically, you put a transducer right on it. Every time you do that, you are never at the ampulla. You are always distal to that. So you have to pull the scope a little bit back to get to the ampulla until you see a PD and the bile duct. So then, absolutely. Okay, and Mustafa explained that so already. So the other way to take a look at the ampulla is you find aorta, the 5 structures I explained, and then do your right and left rotation and move the scope. Basically, it's a right and left torque to take a look at that. So that's the way to do that. Yes. This is station 3, which is a duodenal bulb. That's the you're looking at. यार इसका वॉल्यूम ज़रा दोबारा करो. ये इस मेरे ख्याल इसको डिस्कनेक्ट करना पड़ेगा ना आप. हाँ, हम इसका नहीं चल रहा वॉल्यूम अभी. वॉल्यूम है. दोनों में है. तो चलो कोई बात नहीं, ठीक है, खैर. So this is station 3. You can see that going from the stomach through the pylorus into the duodenal bulb. And again, it's would be easier to explain during the live case. But one thing the way I'm going to explain is you get into the duodenal bulb, have an endoscopic view of the duodenal apex. Okay. So don't pay attention to the EUS image yet. Have an endoscopic view. Look at the duodenal apex. Your goal is to put the transducer in left upper corner of the duodenal apex. Okay. You touch that with the transducer, big wheel towards you, suction the air, and then rotate the scope to the right. So when you rotate the scope to the right, this is the image you are going to get. Okay. So you will see, you will find one of the 3 structures, portal vein, bile duct, or pancreatic duct, or sometimes 2 of those, sometimes all those 3 of those. So even if you find one of those, you can use that as your guide to find the other. So the goal is to find all those 3 structures. So here you can see the bile duct right there. You can see the pancreatic duct right there. You see a portal vein. This is a splenic vein coming here. This is SMV making a portal vein going towards the liver. it really depends, again, where your transducer is and how you are looking from these structures. So when you are looking at these structures from the stomach, you will see it totally differently. I'll show you that in a minute. Like you will see the pancreatic body, then you see a splenic vein, then you see SMV coming, making a portal conference, which is going downwards into the liver, okay? And the bile duct is on the other side of the portal vein. But when you go into the duodenal bulb, you are resting on the greater curvature, and just consider that you flipped your transducer upwards. First you were looking from the top down, and now you are looking from the bottom up. So everything flips. In D1, when you are in the duodenal bulb, that's why the bile duct is closer to the transducer and portal vein is away, because first consider you are looking from top down, and now you went down and looking up, so everything flips. Here, this is a bile duct, this is a pancreatic duct, and I said this is a SMV, and I said the splenic vein is here. So that means splenic vein is coming from here. So this is left side of the patient, right? So the pancreas is not here. Rest of the pancreas is here. This is the neck area, body is here, and the tail is here, okay, when you are in the D2. So you have to get that concept, okay? And I mean D1, sorry, when you are in D1. So you have to get that concept registered in your mind. And this is going to be, you have to think about that. You have to look at the atlases, and you have to look at the videos. You have to imagine how that's going to work. Of course, yeah. So everything is on that side, okay? Splenic vein is here. Portal vein is going upwards towards the liver. Liver is here right now, okay? So when you are looking from the stomach, liver is here. Okay, when you are in the D1, liver is up here. Okay. जी? इधर कुछ भी अभी तो नहीं. Liver is supposed to be here. Yeah, it's a different way, because when you are moving the transducer, first you are looking at that, and then you are moving the transducer like that. So position changes. You won't see a liver and spleen in the same angle from D1. From D1, you won't be able to see spleen. So you keep moving the transducer with your torquing movement. So the things keep changing, and anatomy keeps changing. So from D1, you won't see a spleen. Okay.
You'll just see the splenic vein going away from you. Yeah, it's going away from you.
So station 4 is like, this is for me station 1, remember, okay? So here you see the celiac artery, celiac axis and celiac artery. How many branches are of the celiac artery, the main branches? Which ones? 1% at a time. Anybody else wants to try? Okay. And common hepatic. So left gastric, usually the first one, which comes off the celiac, and then it divides into the splenic and common hepatic. Sometimes there is what we call a trifurcation. So all 3 branches come out at the same time. So what's the first branch of aorta below the diaphragm? Celiac? But left gastric is coming off the celiac. Okay. And phrenic artery. That's a trick question. Okay. It's the phrenic artery, not the celiac. Okay. But celiac is like right under the diaphragm when you see the crust of the diaphragm. So you see the celiac, but that's really not the first branch. Before that, the phrenic artery comes up. Okay. Okay. So this station 5 and 6. Oh, actually, I didn't even show the station 4, right? Okay. Okay. So station 4, you follow, the goal is to find the celiac artery, and you follow that. There's going to be a first branch of the celiac, which is going to be left gastric. You're going to see that here, hopefully, it shows right there. You see that? It's going towards the right. So most of the time when you are scope is you have a scope straight, the left of the screen is right of the patient, right of the screen is the left of the patient. Okay. So when you follow the celiac, when it divides after it divides into common hepatic and splenic, you follow the splenic, and that would take you to the pancreas. Okay. So from pancreas here you see that this pancreatic duct is going to come around the portal vein, and that's the area of the neck of the pancreas. You see that this is a duct right here, this is a portal confluence. Now the liver is here, okay? And so you see the bile duct right here, that's a bile duct. So this is on the other side of the portal vein. When you are looking from duodenal bulba D1, it was closer to the transducer, and now it's completely on the other side. Okay, so this like it's just constant movement of the transducer from one place to the other place. Okay, so every time you make a movement, your orientation changes. So you have to get used to that. And if you get lost again, go back to the familiar station and start over and go from there. Okay, so five.
In this station, whatever is above the splenic vein and between the splenic vein and transducer is the pancreas.
Not necessarily. Not necessarily. Depends on how your position is. But usually when you find the splenic vein, yes, that's going to be true. Yeah, because the splenic vein, what we say is makes the bed of the pancreas. Okay, so it's going to be that. But many times you get lost, you see this whitish area, and you see there's a vessel, some vessel around. It could be a renal vein or some other vessel, and you're thinking it's a splenic, but you're looking at the retroperitoneum, which you are thinking it's a pancreas. Okay, so that's a retroperitoneal fat. So you're going to get lost all the time. The trainees get lost all the time in that area. So it's just, again, more you do. And what I say is, like, your goal is to bring the splenic artery and splenic vein to the right of the screen. When you have those two together, that's where you're going to have a pancreas, pancreatic body. Okay?
For the descending, so we should follow the descending, or we start from the liver and then we turn toward the aorta?
Say it again.
We should start from the liver when we are at the G junction, liver and then turn towards the aorta, or aorta and then towards the liver.
Doesn't matter, whatever works for you. Okay, start at the GE junction. And what I'll show you is I'm going to find the left lobe of the liver. Yeah, so I always, it's my way of doing it. So you can develop your own way. And that's how I teach it. That's not how I was taught. Okay, so but that's how I teach it. That's how I made my own routine. I look at every, I have kind of 5 things in my mind which I have to look at it, otherwise I can't sleep well. Okay, so I really, at every EUS I do, I have to take a look at those. Okay. So station 5 and 6, they are mainly a mediastinum. Mustafa already showed that a little bit. I think it would be much easier to demonstrate during the live. But main 2 things you are looking at is the subcrina and the AP window. And the AP window, which we call the AP window, on EUS is really not a AP window. That's a little bit above what we see. AP window is down. We really, most of the time, we cannot see the AP window because that's a little bit away from us. And it's actually, main utility is in lung cancer. If you take a look at lung cancer and mediastinal pathology, okay? So what happens is, if you look at the subcrina, you can find lymph node 99% of the time in normal people. You can see that. When you start seeing lymph nodes in AP window, and there is some concern of some pathology, those may be a pathological lymph node. So that's the main difference. That's why we take a look at it. Normally, you don't find lymph nodes in AP window. Okay, so that may be in the TB, maybe in the, some fungal infection.
For the GI practice, AP window is not really.
Not, for the GI practice, the thyroid is not important too, but I have done FNA of that too. So, okay. So here, this is a complete exam, okay, of the pancreas. You can see that I'm right at the G junction. The first thing I usually go is towards the left lobe of the liver. So what I'm going to do is I'm going to keep stopping the video and keep asking you guys what that is, okay? So first thing I told you, the left lobe of the liver, okay? We're getting there. I think we'll be done in 5 minutes, okay? So here you see the left lobe of the liver, right? Okay. From there, sorry guys, pressed the wrong area. So again, at the left lobe of the liver, I'm right at the aorta, right? And you see something here. What is that? Okay. So what is that then? If this is the crust. So yeah, it's a celiac. It's a celiac. Okay. So I don't think it's gonna work, I guess. So anyway, let me go through this. Okay. So that's the celiac. You see that? Okay, I'm going to turn it on again, and you will see the 3 branches coming up there. You see the left gastric came off, and I'm following the spleen, as splenic artery. When I followed that, and that took me straight to the pancreas, okay? I look at the pancreatic body. If I rotate the scope to the right, other thing is whatever really you want to see, one of the principles of EUS is whatever structure you want to see, try to keep that between 4 o'clock and 8 o'clock and follow that structure. So the best thing would be if you can keep it between 5 and 7 o'clock. So here, our landmark is the pancreatic duct. So my goal is going to be to keep that between 5 and 7 o'clock position, and I will follow that as my landmark and take a look at the structures around that, okay? So whatever you want to examine again in EUS is try to keep that underneath the transducer and close to the transducer. So here, so you see, we talked about that this is the pancreas and pancreatic duct, and this is, what is that? Left kidney. So you see the cortex, which is a little bit hypoechoic, and medulla, which is hyperechogenic, okay? So that's where you see the left kidney, and I'm going towards the tail of the pancreas. When I go to the tail of the pancreas, so you see then another structure comes up. What is that? Spleen. So the tail of the pancreas is really tucked in between the spleen and the left kidney sometimes. So you have to take a look in the gap between the spleen and the left kidney to really follow the whole tail. So from here, after you have looked at the tail, so this was the movement which we made, keeping the pancreatic duct there in the center. We made a movement to the right torque, and usually you have to pull the scope a little bit back. But don't pay attention to all the movements which are taught to you, because those the body is, every person does not read the book. Every patient does not read the book, okay? So you will have some variation. Sometimes you just may have to advance the scope a little bit. The goal is whatever structure you are examining, you have to keep that in view and do whatever it takes to do that. So it's not always going to be slightly pulling the scope back and rotating to the right to go towards the tail. Sometimes it's not going to do that. So you may have to push the scope a little bit to get to the tail. So goal is, again, to keep the structure you want to examine underneath the transducer and do the scope movement, whatever it takes to keep looking at that structure. So here, one thing is, first we went to the right. Now you're going to do the opposite of that to go to the, it's just you did one movement and now you have to undo that movement, and you will have that structure right there. You saw that portal vein conference here. This is going to be a I'm going to go back a little bit. So when you go into the duodenal bulb, I know I said that, and I'm going to say that again and again and again. Okay, 80% of the time when you do this maneuver, you will get one of those structures, either a portal vein or a bile duct or a pancreatic duct. Look endoscopically as soon as you get into the duodenal bulb. Look for duodenal apex. Your goal is to put the transducer, if here is the duodenal apex, your goal is to put the transducer in left upper corner, touch the wall, suction, and then rotate a little bit to the right. When you do that, you will find one of those structures again, either one of the ducts, bile duct or pancreatic duct, or you will find the portal vein. And when you do that, then you can move your scope right and left and find the other structures. Even if you can find one of those, you can find the other ones. You can see here bile duct, pancreatic duct coming close to each other. This is a portal vein, and those are the same structures we already talked about. Here, when you are in D2, you can see that the bile duct, pancreatic duct, and now this movement, I think I'm going to do the movement and take a look at the whole pancreas, literally with one movement coming back. Now I'm coming back to the stomach. I'm in the stomach. There is a pancreas right there, and all the way from body towards the tail, you see the kidney is going to be coming up here, and that's like how much time it took. It was not edited, that part. It literally took 10 seconds, not even that, to go through the whole pancreas from all the way from the D2 to the tail of the pancreas. So this is a mediastinum. Again, I'll explain that better during the live endoscopy, what your movements should be. So I think, yep. So you start from the ampulla. First, I like that's my last part of the pancreas exam. Like first, I start at the G junction, take a look at the body and tail and the neck. I go to D1. I take a look at the head and the neck again. I go to D2. I look at the uncinate head again, and also the to some extent neck of the pancreas. I've looked at the whole pancreas. And now I want to take a look at the whole pancreas one more time. So I don't want to have to come back and do it again. So I start like I'm undoing what I did before. So going in, looking at the whole pancreas, coming back, looking at the whole pancreas. Okay. So I think these are some numbers which have been given, but in reality, I think you really need 200 supervised exams to really get an idea about what the EUS and the exam is like. So I know it's difficult. There are other ways to do it. The way we did it here started 7 years ago almost. You do it like we did a week. In a week we did like 60, 70 cases, and then and Dr. Saad did on his own for 6 months, and then I came back, and whatever difficulties he had, we did another one like that, and now he's better than me. Okay. So okay. So that's it. This is our hospital, by the way, and these are my. There's one partner missing. I think I need to put that picture on. This from last year. Sorry. So that's our hospital, our endoscopy unit. I think Gasbhai, you have seen it, right? Yeah, you have. And our endoscopy unit is right here. And this is one of the hospital. Now there is another building behind that, another big hospital.
The unit is better than the hospital.
From outside it looks an older one, but they have from the inside it is true that it is really better than the hospital. Okay. So this is about the stations. I think we'll do some cases, and towards the later afternoon I'll talk about FNA and FNB today, and then I think these are going to be all the lectures for today. One more and then that's it. Okay.
Thank you, Khalid. Thank you, Mustafa. Sorry, I had to